First of all, welcome to all of you. Today's most interesting and most knowledgeable topic, Chandipura virus, which is a very important topic for all of us. We are going to discuss on behalf of College of GP IMA Gujarat. This topic will be presented to you all of by Dr. Speaker Dr. Abhay Shah sir. First of all, I welcome Joint Secretary CGP IMA Dr. Vanraj Sir Mehra, Director IMA CGP Gujarat Dr. Jaswant Sir Darbar, Secretary IMA CGP Gujarat Dr. Jitendra Shah. Sir, all of you welcome. I heartily welcome to all of you. Now I invite Dr. Jaswant Sir for opening remarks.
Good afternoon, dear friends, respected speaker, dear healthcare, and all participants. It is my privilege to welcome you all to this important webinar on Chandipura virus, what you should know. Any emerging infection is always challenge to public health, and staying informed is our best defense. Today's session will definitely provide us an opportunity to understand the virus, recognize its symptoms, and learn preventive measures. And we'll definitely discuss the vital role each one of us will be playing to protect the community. I sincerely thank our esteemed speaker for sharing their valuable knowledge. And as we know, early detection and timely treatment reduces mortality. So I hope this webinar will help us understand and take appropriate action. Thank you.
Thank you. Thank you, Dr. Jaswant sir. Now I invite Dr. Abhay Shah sir. Sir is senior pediatrician and consultant in pediatric infectious disease, Ahmedabad, Gujarat. Sir was gold medalist during his MBBS. Sir is past president Academy of Pediatrician Gujarat, national president infectious disease chapter of India 2015. Sir is vaccinology and infectious disease specialist, and these all are his area of interest. I heartily welcome Dr. Abhay sir. He will speak and give knowledge about Chandipura virus. Sir, please.
Yeah, okay. So thank you very much, organizer, especially Dr. Darbar sir, for giving me this wonderful opportunity. And let me first share my presentation. Is it visible?
Mm. Yes, it's visible.
Yes.
I'm audible?
Yes.
Yes, sir.
Okay. So the topic that has been selected today is very apt as per the current setting and epidemiology that is going on since last 2 or 3 weeks. So we'll start with some case presentation. So that will help me to sensitize the participating delegates. So here's a 12-year-old male child who has been vaccinated up to the age of 5 years as per the urban center and has a very short acute history of high-grade fever 100 to 103 for 5 days. The projectile non-bilious vomiting 3 days, decreased oral intake, but more importantly, the child also had some CNS issue. He was sleepy, he was quite irritable when approached. It was followed by some irrelevant speech. And over the course of the illness, child also suffered from a generalized tonic-clonic convulsion with uprolling of the eyeball, with frothing from the mouth, which lasted for more than 5 minutes. It was again controlled with the help of the injection lorazepam. So here a febrile child is there who has some CNS manifestation. So if you look, the child was having altered sensorium. You can see very high grade fever. General exam was totally normal. Or on CNS examination, there was altered sensorium, irrelevant speaking, child was disoriented, cranial loss was normal, muscle tone power was normal, plantar's extensor, and the signs of meningeal irritation, there is cornic sign, Brugge's neck region were absent. So this probably rules out meningitis as a cause of this CNS manifestation. So the question I would like to ask all of you, of course, here it's not it's an online topic, so we will not interact. But what are we dealing with? So previously we used to say that it is fever with CNS manifestation. or sometimes we used to use the terminology febrile encephalopathy. But now the term which is used is an acute encephalitis syndrome, popularly described as AES. And this terminology has been coined by WHO in 2006, which defines a person of any age. Remember, each word is very important. Any age, at any time of the year, not necessarily in the monsoon, with acute onset of fever, with at least one of the following, that is, change in the mental status. Of course, our child is having that disorientation. There is new onset of seizure. Child was also having convulsion, which is not amounting to a simple febrile seizure. And sometimes child may have abnormal behavior, somnolence, irritability, or some speech disturbances. So when this constellation of syndrome are there, which does not fit in the category of the febrile seizure, this child should be designated as acute encephalitis syndrome. And if you look at this, the spectrum of the illness, it may be because of some infection, or it may be because of some non-infection condition. Infectious diseases are more common in India, and the common viruses that we encounter day-to-day practice as Japanese B encephalitis. Of course, the JE encephalitis is not there in Gujarat, but I think it is quite rampant in our neighboring states, and it's an endemic disease. And the government of India is also providing free of cost vaccine to this for this JE vaccine. So it's such a dreaded rampant disease. Fortunately, Gujarat is not the culprit currently. And we have got the HSV, entero, dengue, chikungunya, Chandipura, number of viruses. Even cerebral malaria can present like this. And in the bacterial meningitis, TB meningitis, rickettsia, brucella, brain abscess, all can present with a infectious cause of the acute encephalitis. Among the non-infectious causes, we have got the ADEM, we have got Ray's syndrome, inborn order of metabolism, autoimmune encephalitis, and some poison, drug-induced, and sometimes even head trauma, accident, injury can also present with encephalitis. So this is the broad classification. Now, let us concentrate on the AES. If you look at the various causes of the AES over the 4 years since 2000, the commonest, the most important is the JERS, scrub typhus, dengue, chikungunya, leptospira, and others which include flu and chikungunya and varicella, mumps, etc. So, up till now, Chandipura virus was not recognized as an important cause of the acute encephalitis syndrome. But in 2024, in Gujarat, we had a 20 suspected Chandipura virus deaths in Gujarat. And following that, I think number of viral infections, the common I already told, I will not go disturb, but you look at this, the Chandipura virus, the outbreak was there in Andhra Pradesh in 2003, in Gujarat 2004, in Nagpur 2005 and 7, and this is an outbreak. And sporadic cases, chuta chawaya cases was also recognized in Andhra Pradesh in 2005 and 2006. So, though we are more sensitized in the last 2 or 3 years, this disease has shown its sporadicity, endemicity, and outbreak potential as early as in the year of 2003 in the various states of India. And if you look this Chandipura encephalitis virus, it is not a virus. It has been associated with a number of encephalitis epidemics in the different states that I told. Andhra Pradesh 2003, Gujarat, Maharashtra, and in Orissa. Also, the outbreak was seen in 2015. Now, in the July 2024, total of 78 AS cases were reported in Gujarat, 75 from Gujarat, 2 from Rajasthan, and 1 from Madhya Pradesh. And out of these, 28 cases resulted in the mortality. And amongst the 76 tested sample at the National Institute of Virology, Pune, 9 have been confirmed positive for the Chandipura virus. So all these 9 positive cases and 5 associated deaths are from the Gujarat. So I think it's a signal, a warning signal as far as the Gujarat health officials and the regulatory health authorities are concerned. And look at the current dashboard in the Gujarat in 26. 32 suspected cases recorded statewide since July 126. 7 confirmed positive cases, 12 negative, 8 cases results are pending, 3 confirmed child deaths, all under 10 years of the age, and critical care is provided to 4 confirmed patients. Currently, they are on the ventilator support. And the key districts which are affected currently is Sabarkantha, Panchmahal, Aravalli, and Mahisagar. So these are the district areas. Remember, now the transportation is so much fast and so much frequent. I think this virus can enter to any of the district of the Gujarat. And therefore, we have to be very, very vigilant. And the age group which is at highest age is below the age of 15 years. So it's a disease of the pediatric age group. And the virus advances so rapidly that it can become fatal within 48 to 72 hours of the development of the symptoms. So it's a very dreaded virus to have. Now, it is very important that we are observing a cross-border travel. The entire world has now become a global village, and therefore the transportation and communication becomes so fast that the disease cannot be confined to under a single boundary. And look at this, the infected children from the neighboring Rajasthan and Banaskantha have been shifted into Gujarat Civil Hospital for the critical care. So I think it is very, very important. And as per the 2026 Government of India assessment, they have highlighted that the vector, that is the sand fly, is more commonly found in the states of Karnataka, keeping regional health hubs on the standby. So I think the disease can also spread to Karnataka as well. Now, if we look at this endemicity, seasonal outbreaks tend to occur during the monsoon months, and it coincides with the highest vector activity. The endemic regions I have already discussed: Andhra Pradesh, Maharashtra, Gujarat, Madhya Pradesh, and alarming high fatality. You look at the fatality, 55 to 75%, means nearly 3/4 to half of the child will die if they have got the Chandipura virus. And the first isolation that has taken place in 1965, but the large-scale epidemics have been reported in the different states. Now, let us look at the virus and the vector. This virus was discovered during an acute febrile illness from the Chandipura village of the Nagpur, Maharashtra from 1965. Yet it was isolated from the patient who is residing in the Chandipura village. The virus is known as Chandipura virus. It's a rhabdovirus, primarily causing acute encephalitis syndrome, and the virus is genetically related to rabies virus and shares the characteristics of the bullet sheet morphology, which is typical of all the rhabdoviruses. The vector you can see in the picture is a sandfly. The species that belongs to that is a Phlebotomys species. The sandflies are the primary vectors, but the mosquito can be the secondary virus, a secondary vector. However, the role of the vector in the dissemination of the disease has not been found that very clear. The breeding site of these sandfly are mainly in the cracks in the house and in the tree cracks. So, in holes and services in the wall, holes in the trees, dark rooms, stable rooms. Also, the disease is more common in the rural area, especially in the monsoon area where the humidity is going to be there and there are a lot of cracks in the village huts. If we look at the pathogenesis, because of the vector bite with the help of the sand bite, the virus will enter into the skin. There will be a local replication. It causes primary viremia. That means the virus enters the bloodstream. Then there is systemic dissemination. It crosses the blood-brain barrier. And a CNS invasion takes place. And as a part of the neurotropism, it infects the neurons. It activates the immune response, gives rise to cytokine storm, which in result turns into a glial cell activation, and this results into neuroinflammation, cerebral edema, neuronal necrosis, and perivascular coughing. And because of this neuroinflammation, cerebral edema, perivascular coughing, and neural necrosis, child will develop as an acute encephalitis syndrome and manifest to us as a fever, seizure, altered sensorium, which progresses rapidly to coma and even death. And so, why it is so fulminant? So, the exact cause has not been detected, but the fast replication of the virus in the neuronal cell and the rapid destruction of the neuronal cell giving rise to apoptosis is the basic mechanism for this fulminant encephalitis. And it is usually a pro-inflammatory cytokines which causes cytokine storm in the body, resulting into the perivascular lymphocyte infiltration, microglial nodules, and massive neuronal necrosis. So one of the most important characteristic of the pathology created by this virus is a necrotizing encephalopathy. And once the necrosis takes place in the cerebral tissue, regeneration is not possible. We know that it is an intrinsic quality of our neurons. So that once there is a necrosis, necrotizing encephalitis sets in, I think regeneration of that tissue does not occur. And that is why the disease is very, very fulminant. So, as I said, that pediatric age group, especially from 9 months to 14 is affected. Male-female ratio is 1.077. So, male are always at disadvantage. Incubation period is very short, ranges from 1 to 6 days, though most symptomatic patient comes within 2 to 4 days after the bite of the sand fly. So, that is a short incubation. And usually they present with a very high grade fever, 102, 103, 104, which is not responding to your antipyretic. Second, the child will have a vomiting. Remember, the vomiting is non-bilious and projectile. Sometimes because of the viral dissemination GI tract, there may be diarrhea. Headache is found, especially in the older children who complains of the headache. Usually the altered sensorium, stupor, coma, obtundration is common. They usually present with generalized convulsion. If the child is not attended in time, it leads to disabling posture, grade 4 coma, and within several hours it may become fatal. So it is one of the very important fatal cause of acute encephalitis or the encephalopathy. And sometimes we have seen that death can occur within 40 to 72 hours. Some patients will have an atypical features, which includes photophobia, papilledema, hemiparesis because of the stroke-like features. So this is one virus which can present as a cerebrovascular stroke, and they present with the hemiparesis. Now, the rapid deterioration is the exact site of the lesion is not identified in many of the cases, but majority of the cases, the site of lesion was found to be the area which is supplied by the middle cerebral artery. And remember that there is no clinical evidence of the direct invasion of the pathogen. So it is not that the biopsy will identify the virus, but it causes the neuroinflammation. And this neuroinflammation is mainly because of the cytokine storm. Sometimes it may mimic like Rett syndrome with gross brain edema, but hypoglycemia and high SGPT, which is very typical of the Rett syndrome, is not found in a case of Chandipura virus. So that is about the area, that is the area which is supplied by the middle cerebral artery are often affected. As per laboratory concern, it is very important to send the serum sample as well as the CSF sample. Ideally, all viral studies should be done at the National Institute of Virus, Pune. But now, because of this current setting, probably Gandhinagar and other regional laboratory has also started doing the testing. The serology test will consist of the IgM and IgG, mainly by the ELISA. Now, IgM will be detected by up 4 days and IgG will be detected by 7 to 10 days. But remember that the disease is very fast. The incubation period is very short, and therefore the sometime this virus or the disease will not give proper adequate time to develop the antibody response, and therefore before your antibody cell test comes positive, by that time the child would either have survived or the child will have to become fatal. And therefore, serology is not an ideal test as far as the diagnosis of the Chandipura virus test is concerned. So, what is gold standard? The gold standard is our RT-PCR, which detects the RNA of the virus in the serum as well as in the CSF as early as on the day 2 or day 3 during the acute phase of the illness. So, it is the most important, most sensitive and highly specific test, and this is the test that should be carried out in all the government sector. Serology is a waste of money, and probably it may not give much time to develop the antibody. The disease and the virus is so fulminant. Now, another confirmatory test is a virus isolation using the cell cultures. So, but this culture facility is not available. It is mainly for the research purpose, and the specialist laboratory there are there. So, for all practical purposes, it is the clinical feature, the epidemiological background, high index of suspicion, and if available, your RT-PCR to detect the Chandipura virus RNA. These are the 4 important basic foundation for the diagnosis of the Chandipura virus. Now, if you do the CSF, it may be completely normal. Sometimes there may be some cellular response, that is mild pleocytosis may be there. Proteins are usually normal. Sugar is slightly reduced or maybe normal. So, by and large, CSF examination will not give much of the biochemical changes or the cellular response. But this CSF is very, very important for the RT-PCR, in which we detect the RNA sequencing. As far as the MRI is concerned, this MRI is concerned, imaging is concerned, they have a non-specific features like cerebral edema, but they do not have any typical finding. Like our Japanese encephalitis, there is involvement of the basal ganglia, which gives us a panda cell, a panda sign positive on the MRI film. In case of the HSV, probably we will have a temporal lobe involvement. In case of the polio, we have got the anterior horn cell involvement. So here this typical prediction for a particular area is not there, and the MRI changes, even the CT changes are non-specific and mainly in the form of the cerebral edema, and sometimes it is majority time it is associated with necrotizing encephalopathy. Now, since there is no specific antiviral is available, the management is the supportive, and what is most important, that early detection, early suspicion, and early transfer to a higher center is very, very important. We should not waste this golden moment of the primary stabilization. And this stabilization includes airway, breathing, circulation, along with the euglycemic control. Your blood sugar should be maintained. They are more prone to hypoglycemia. Therefore, sugar should be controlled. If the seizure is there, you can seizure control with the help of the proper anticonvulsant like lorazepam or like levetiracetam can be done. If there is a cerebral edema, you can give mannitol or the 3% normal saline. And if there is hyperpyrexia, usually the child is not able to take orally. So we usually give the upper rectal paracetamol, or sometimes fever is so high that sometimes we often use per rectal diclofenac sodium. The dose for the per rectal paracetamol is 15 mg per kg per dose. And for diclofenac, the dose is 3 mg per kg per dose. So the $1,000,000 question, is there any role of the antibiotic? Remember that today we are dealing with the outbreak of the Chandipura. But all cases who present with acute encephalitis does not give a guarantee this is Chandipura virus. It may be different cause of encephalopathy. And therefore, when such a serious child is there, we always cover them with a broad spectrum antimicrobial agent until the diagnosis is confirmed or the diagnosis is ruled out. So whenever any child who comes with acute encephalitis syndrome, irrespective of the outbreak pattern, epidemiology, something like that, we always give them IV ceftriaxone. If your area is endemic for the scrub typhus, we add doxycycline. And the HSV, herpes simplex, is the commonest cause of the sporadic encephalopathy, which is treatable, and for that acyclovir is available. So in addition to all this supportive management, ceftriaxone and acyclovir should be added in all the cases. And if you are living in the area where rickettsial disease or scrub type is known, you should to add upfront doxycycline. As far as Chandipura virus is concerned, there is no antiviral is available. So once you confirm that your case is having Chandipura virus by RT-PCR, then you can stop all these antimicrobial agents. So that is how we can become a steward as far as the use of the antimicrobial is concerned. Other important measure is to reduce the raised intracranial tension. And for that, we have to have an anti-tendinable position for 30. I think this has been taught very well in our medical school. It is better done than better discussed. So I think it is very important. Then mannitol, hyperventilation sometimes required. And if there is a uncal herniation or refractory ICP, then in that case, a surgical decompression may be advised. So these are the modalities as far as the brain salivary therapy is concerned. Now, as I discussed, that majority of the patients are from the rural area, and they usually go to the primary health center. And therefore, when the ICU is not set up in the periphery, you have to shift the child very safely from primary health center to ICU. And during that time, you have to maintain the airway. You have to control the seizure. If the IV access is not possible, I think now the nasal midazolam is available. Buccal or rectal preparation is also available. If you can get the IV access, it is well and good. Similarly, PCM suppository, a first dose of the antibiotic that I have discussed, and a good referral note. This and there should be an accompanying medical person and paramedical person. I think this is a very important golden hour management to salvage the child. If you transfer the child with this facility, the airway may be collapsed, child is in comatose child, and there may be a sudden flexion of the neck, your trachea will be completely closed and child will die immediately. So I think this stabilization during the course from primary health center to PICU is very, very important. Prognosis, usually I said 50 to 70% for mortality, and in survival there will be complete recovery without any sequelae, but it is highly fatal and death can occur within 72 to 96 hours. As far as the preventive measures are concerned, a liberal use of the effective insecticide. Amongst them, DDT and 5% malathion is very important. Always use the repellent nets. I think it is good to invest money in these two products. Fly papers are not available, but the strips of the paper, I've seen the figure coated with the sweaty fragrant material, which is extremely sticky, and they will trap the mosquitoes or sandflies. Always wear the full sleeve clothes. Avoid water clogging or do not go outside where the water puddles are there. You must repair the cracks in the house and the huts. Trees should be well maintained. The vaccines are in trial, so as such, there is no vaccine currently available. And the most important epidemiological intervention is that once one case of the Chandipura virus is detected, you have to screen the 50 yards of the breaching place, because this is the area where the sandfly up to that can travel. So I think you have to screen 50 yards of the breeding area, and always health education is the order of the day. What the government has done for this action plan, there is a high priority health emergency demanding rapid containment. That is most important. The marathon dusting has been carried out by 50 field teams, and they deployed for the massive powder. Targeted spraying, that is insecticide application in the mud, houses, cracks, and the shelters. Breeding source reduction, elimination of stagnant water, and the organic material is there. And focus area, they have now prioritized 61 historical output locations. So from the past experience where this sandfly is there, they have identified 61 outbreak spots, and this focus area has been under constant scrutiny. The most important part is the active surveillance and screening, door-to-door screening, and for that need to education of the health worker is very, very important. So they can actively track the cases of the acute encephalitis syndrome and refer to them. Early detection, and therefore the medical team is to be there. So doctors, paramedical staff must be aware of this virus and the progression of the disease. There should be a fast-track diagnostic. Rapid sample collection, transport are very important, and the regional laboratory should be designated for that. It is not that always we go for the Pune. It is very difficult. It will take 2 days for to reaching the Pune. No, we need to have our point of care test, whether results are available within 2 or 3 hours. I think this type of the laboratory setup is very, very important. And once you identify the case, a contact tracing, like our TB, the contact tracing is very important. So immediate monitoring of the cluster around any newly confirmed case is very, very important. Standard protocol, which has been designed by the IMA, IAP, or medical society. I think this is very, very important. So you have to publish this guideline and send it across all the health workers. Maybe paramedical health workers, which indicates the dose of the penetol, dose of the anticonvulsant, how to maintain the airway. So all these are very important, and there should be a figure and graphs. Similarly, there should be a pediatric, since the disease is more than pediatric. I think pediatric isolation wards are there, and therefore your endotracheal tube or resuction tube, laryngoscope should be available of the pediatric size, not of the adult size. And there should be a working facility, life support infrastructure, and zero referral delay. Once you suspect, it should be immediately referred to the higher authority. I think this is the most important as far as preventing the mortality associated with disease. So zero referral delay is the most important golden sentence as far as this disease is concerned. And so strengthening laboratory facility for the RT-PCR at district level will enable us for the faster identification cases and implementation of the control measures. And if a vaccine, 2 candidate vaccines are there, recombinant vaccine and the kill vaccine, and they both are in the preclinical stages. So as of now, the vaccine is very a far dream, very, very important. But we have the challenges, positive data, lack of easy low-cost microbial testing, lack of specific treatment, lack of facility for the intensive care in the periphery, lack of facility for the imaging, neuroimaging in the periphery, patient delay in seeking the healthcare, and inappropriate supporting care. So the challenges are huge. The disease is fatal, challenges are huge, resources are limited, but whatever is available, we have to apply it with the full force. With this, I thank you everybody for your patient listening. If you have any question, I'll be very happy to answer. Thank you so much.
Thank you.
Yeah.
Yes. Thank you very much, sir. Heartily very much thanks to our speaker, Dr. Abhay sir. Sir has nicely covered detailed study of Chandipura virus, golden hour of management, how early reference is important, and ABCD of preventive measures, and active surveillance, how active surveillance is important. So I think everything is covered in detail. So now I invite question and answer from our participants or and our viewers. If any question and answers.
I think there is no question. Dr. Maida sir is with us. Dr.
Yes.
Maida, would you like to say anything?
Hello, it is hello, sir. Actually, I love to hear you and very well described. So I would like to appreciate even, and the effort is very good. Actually, do we record the lecture, sir, Darbar sir?
Yes. See, this lecture will be in our GSB YouTube channel for a permanent
Yes.
stay.
Yes, then it is very good because actually live.
Anyone can access this from now onwards. Even it was live now. Okay, no problem.
Actually, Darbar sir, actually આનું આપણે ફ્લાયર એક બનાવીને સોરી